Yeah, well, it's a pleasure to be here. Thanks for the invite. I do have the distinct honor of being the fellow who traveled the least. I practice a half a mile north of here. Later on I'll have to ask you how you had the insight to ask me about my expertise in dissatisfaction. It's not just knee replacements. But here are my disclosures. We'll get into it. The biggest disclosure is that I'm an advocate for the medial stabilized total knee. I use it in just about everybody. Total knees, it's a common operation. We all know this. It has measured benefit for individuals, but society as a whole is measured in qualities. And as we just saw, there's going to be an exponential growth, and we're in the middle of it, that curve into 2030 for utilization. We frequently cite the goals of this operation to be pain relief, restoration of motion, function, kinematics, and having a lasting outcome. And you'll hear over the next kind of day and a half here that most of us believe that the results are predicated on proper implant placement, fixation, and balance, but I'm here to challenge you. It's not just that. As we go through the concept of dissatisfaction in total knees, I want you to keep this concept in mind. It's Herzberg's two-factor theory for dissatisfaction. There are separate sets of mutually exclusive factors that either drive satisfaction or dissatisfaction. The opposite of satisfaction is no satisfaction. It's not dissatisfaction. An example would be pain. Pain after a knee replacement. That's quite obvious. That's a driver for dissatisfaction, but we'll get into more of them. We'll talk on four major themes: socio-demographics, pre-operative factors, intraoperative stuff, which is what we're most interested in, most of us, and post-operative factors. So this was recently published from the Forest database, which those of you who are unfamiliar with it, it's a federally funded large database housed at University of Massachusetts, run by PhD sociologists. And they identified some sociodemographic factors that were related to dissatisfaction after knee replacement at 5 years. And in their whole data set, the dissatisfaction, depending on how you ask the question, was about 15%. Age, less than 50, was quite obvious. Elevated BMI, disability, education level, race, smoking, insurance level. Those were all linked or statistically related to dissatisfaction at 5 years after arthroplasty, agnostic to implant. Some other preoperative factors included both disease-specific as well as global health scoring systems, both on the mental and the physical component, global disability, elevated levels of infirmary, and the number of other painful total joints. The literature is replete with other factors that have been linked to dissatisfaction, be that you have an arthroplasty and you don't have a lot of arthritis. We might not meet your expectations. Poor range of motion, a number of mental health things: depression, anxiety, pessimistic personality, catastrophizing, and then in the inverse, resilience and grit are related to dissatisfaction. Activity expectations: if you're looking for something that I can't deliver, you're probably not going to be happy. And then time spent with the surgeon with regards to education. If you don't spend a lot of time with them, they're at a higher risk. Let me go back. A higher risk for dissatisfaction. If you look in the bottom right, that graph, the only group that was very satisfied had a low incidence of depression as compared to the other groups. All the other groups had a higher incidence of depression than non-depression in their satisfaction scores. Pretty significant. Can we do anything with this information? Can I predict whether my patient is going to like my operation or not? And the answer is no. This is very similar with just about anything when we look at risk and arthroplasty. Understanding risk is very different than predicting outcomes, whether you're using logistic regressions or machine learning, where you weight various variables that have seemingly greater relationships to dissatisfaction. No matter how you weight them, you can't really predict dissatisfaction. Intraoperative things, this is how we spend most of our time thinking, or what we spend most of our time thinking about, right? Did I put it in right? Is it sized appropriately? Is it well fixed, balanced? What do I do with the patella? Did I use the right implant? Should I do uncemented or cemented? Should I use some of this technology, right? Did I use the right anesthetic? Is the right cocktail of medications in my local infiltration analgesia? Should I use a tourniquet? The literature is replete with both positive findings and no findings with regards to all of these. The most recent manuscript I saw on tourniquet use indicated that at 1 year, patients who had a tourniquet at the time of surgery were more satisfied than the patients who didn't, which is totally contrary to what we have been hearing for the last several years. The same could be said for implant alignment. Whether it's the hip, knee, ankle, the distal femoral alignment, the proximal tibial, coronal plane alignment, sagittal plane alignment, flexion of the femur, it doesn't matter. It's not linked to Oxford knee score or dissatisfaction. The number one complaint for, can we get that video to play? It should be going automatically. The number one complaint for patients who express dissatisfaction with their knee replacement is anterior knee pain, and it's overwhelmingly so. I think the key issue is AP stability in the sagittal plane for total knee arthroplasties, right? So if you have a good, stable pivot in the sagittal plane, you have a fixed point of flexion, you have improvement in quad power, you have quad efficiency, you have less patellofemoral joint reactive force, less retinacular strain, and less anterior knee pain. This is a knee replacement or not. Look at that knee, right? So I'm replacing that. The knee exam looked pretty darn good, right, before I got there, right? That's a knee that I'm revising for anterior knee pain and sagittal instability. I think this is a key component of dissatisfaction in total knee arthroplasties. Whether it's a CR knee, we know a third of them have paradoxical rollback, whether it's rollback or glide, right? And the bottom right is a graph by a friend of mine that shows 4 knee replacements and 1 normal knee, looking at the instant point of contact of the femur on the tibia per degree of flexion. And there is no consistency. This is not a repeatable and reliable operation if you're doing a CR knee, and it looks nothing like a normal knee. Same thing can be said for PS knees. I see this all the time. This is an over-resected posterior condyle. This patient by definition is going to have mid-flexion, sagittal plane, and rotational instability. They complain of the same things, all of them. They have anterior knee pain when they do weight-bearing and flexion, whether they have effusions that come and go with levels of activity, and they have a sense of giving way. Outcomes in total knee with regard to satisfaction are depressed in weight-bearing and flexion, whether it's kneeling, squatting, getting out of a car on the far left. It's very different. Did we meet this patient's expectations at 6 or 12 months compared to simple things like shopping, walking on level ground? Right, so we looked at sagittal plane stability and cadaveric knees with a custom navigation system, and identified that with medial stabilized knees, both varus valgus and sagittal plane stability in mid-flexion, 0, 20, and 60 degrees, was identical to that of the native knee. It was different at 90. At 90 in an open chain, non-weight bearing, Dr. Blaha will probably fill that in for us, non-weight bearing total knee situation, we did have more laxity than the native knee. When we looked at it in the clinical setting, PS versus medial stabilized total knees, we found in mid-flexion, 30 degrees, medial stabilized total knees were twice as stable as PS knees, right? At 90 degrees, there was a trend, but not significant. Medial stabilized knees are indeed more stable. The clinical outcome scores, patients were more satisfied if they had a medial stabilized total knee compared to a PS knee when we did weight-bearing and flexion activities. That's the target, weight-bearing and flexion activities, right? Statistically, they were happier than the PS knees, and statistically, they were just as happy with weight-bearing and flexion as they were with non-weight-bearing and flexion activities. How about post-operative factors? This is pretty obvious, right? So if you have poor range of motion, medical complications or surgical complications, if you have low or depressed either disease-specific or global health scores, if you have pain or your expectations are not met, you're going to be dissatisfied. I think this stuff is pretty obvious, right? But understanding the dissatisfied patient is a very difficult algorithm. This is a nice representation in which there are feedback loops. If you have a mental health component to it, it's a negative feedback loop, so a mild outcome, if you were a resilient or a high grit patient, you might not have this and you might be more satisfied, right? So mental health is a big factor in dissatisfaction after total knees, and I recommend that you take the customer satisfaction approach to how you do total knees. That will help you maintain that patient's perceived quality and perceived value when they come to seek total knee from you, right? Set and manage expectations, choose your patients, technically execute the proper operation, and choose the right implant. For me, that's a medial stabilized total knee. Avoid complications to the best of your ability and manage them if they occur. Thank you very much.